Today is the last section, another section of special honor to Jorge, and with you and Peter Lieb, that's going to give this conference. I'm sure that everybody is going to enjoy. Tom Lee was a former co-editor of New England Journal of Medicine. Am I right?
Yes.
Yes. And he is currently, let me read it. Is currently professor of the Department of Health Policy and Management, professor of medicine at Harvard. Please, Tom.
Thank you very much. And so I wanted to make a few remarks about the need to redesign healthcare today. And I want to be so bold as to make comments of what I truly believe Jorge would have wanted. I know that I'm speculating in some ways, but I think that my instincts are correct. If we could go to the next slide. Can you advance the slide to the slide that we are at a moment of discontinuity? Okay, thank you. Thank you very much. My job in healthcare is to deal with the bigger picture. How do we pay for it? How do we make it better? And it is a moment of great stress in every healthcare system. Things are changing. It's discontinuity, I put it. I know it's true in the United States. I know it's true in Brazil. It's true in every country in the world. And the reason is that there's been so much progress. And then there's a global economy that's created this sense of crisis. As I describe on this slide, it's progress has led to a great many people being involved in the care of complicated patients, and the result is chaos. There's so many people involved, they don't necessarily communicate well with each other, and the result is quality, safety, and cost challenges. Now, if you could advance the slide, one slide. Please advance the slide. I am very confident that, no, you can go back. Just go back to what I had on the bottom. Just go back one slide. I know from years of being friends with Jorge that if he were alive today and still, in his role, and we were discussing this, he would understand the problem. He would admit it was a problem and a challenge, and that he would do everything he could to rise to the challenge. And that would mean he would be supporting the use of systems that would improve quality and efficiency, and that he would be encouraging young people to do research and create innovations to improve the value of care. So even though this wasn't a major focus of Jorge in his life, I know that he would be showing leadership in this way as well. Now, if we can go on, go on to the next slide now. How do I know this? If you could go on. I know this because examples of this kind of work have gone on in Brazil, and I know Jorge was very aware of it. He was always very supportive of it. Our mutual colleague, Carisi Polenchek, who may well be there in the room, she has worked with me and with Jorge together and many others. Some of you know this work, guidelines that were developed in Brazil defining recommendations for the use of medical interventions. That book is on my bookshelf in Boston. It sits right near my bulletin board, which has, as Cora Ribeiro knows, her translation of a Borges poem, so I have a very strong Brazilian presence in my office. I think the question for us, though, and the question I wish I could talk about with Jorge, is why don't we use such good advice more reliably? So what I want to turn to is that, the conversation I wish I could be having with Jorge. And I would talk about, why do we get stuck in healthcare? Why don't we do a better job of organizing ourselves to deliver better care and deliver it more efficiently? And the reasons that I would cite is that we don't have clarity of what we're trying to accomplish. Like, what is the goal of healthcare? It's difficult to become more efficient if you don't know what you're trying to become efficient at. We know that healthcare is not about immortality. Everyone develops something sooner or later and passes away. It's not about something as simple as health, because we all do become ill at some point. And we have to give people peace of mind that things are as good as they can be. But it's a complicated goal, and we haven't really discussed how we try to measure it. And since we don't have a goal, we don't have a performance framework, we don't have data that reflect what really matters to patients, we don't have data on costs, we're not organizing the teams, and we're not being rewarded financially for improving the value of care. So those are the things that I would be talking about with Jorge, and what I would be, and I'm sure that we would be thinking, okay, how do we take on these problems? We don't just live with them, how do we take them on? And what I would be saying, what I'm saying with my own colleagues is, we call it a strategy of Porter strategy, Gowandi tactics, and Boehmer operations. If we can just go to the next slide, I'll explain a little bit more of what I mean by that. The next slide. The next slide, please. Okay. All right, so these are pictures of three of our colleagues here in Boston at Harvard. Michael Porter from Harvard Business School, Atul Gawande, who's a surgeon at the Brigham Women's Hospital, and Richard Boehmer from Harvard Business School. And I bring them up because, Michael Porter talks about value as the strategic orientation, and I'll say what that means in a little bit. Atul Gawande is famous for describing the World Health Organization checklist for surgery. And Richard Boehmer talks about teams and what makes an effective team that can own the work of improving value over time. Now, I want to say to you, I don't use these three names because I think Boston is so great and Harvard is so great, or these three people are so great. I do it because my colleagues are like me, which is much more interested in gossip than ideas. So when you use the names of three people, they pay attention and they feel jealous, but they can remember what it is that we're trying to do. So believe me, I don't think that, I don't expect people in Brazil to be using the names of these three people, but I hope some of the concepts are useful. So next slide. Okay, so Michael Porter is a Harvard Business School professor, and he talks about value, and his ideas, I believe, really are ideas whose time has come. The reason is because we have to ask that fundamental question that I referred to earlier. What are we trying to do in healthcare? We need some kind of overarching goal. If we were for-profit companies, we would have stock price, but we don't have stock price in healthcare, at least in not-for-profit healthcare. If you don't have some overarching goal, what happens is interactions devolve into gamesmanship, with everyone trying to just protect their interests. The cardiologists want more catheterization labs, the surgeons want more operating rooms, and so on. And the people who win are the people whose work is most well reimbursed in the current payment system. It's not the way to build a healthcare system to take care of populations over time. Similarly, the traditional measures of quality they focus on physicians' reliability in doing processes, and they're useful for making us reliable, and we can defend ourselves from criticism, but we need something more than defending ourselves from criticism in this day and age where we have trouble paying for health care for everyone. We need problem solving. That is something different from defending ourselves from criticism. So in Massachusetts, where we're struggling to provide good health care coverage for everyone, what we've decided is that our goal has to be improvement, trying to become better than we currently are. And what are we trying to improve? Well, it's value. It's the outcomes that matter to patients over the cost over meaningful episodes of care. That is what we feel that we have to organize ourselves to try to do, rather than just do visits. So we have organized a series of teams, and the teams have two goals. First, they have to define value. They have to come up with the performance framework. They have to come up with the outcomes that we can currently measure in version 1.0 and the cost data that we currently have. And then they have to define what should we measure. What are the things that are important to patients that we currently do not capture, but that we ought to, so we can begin to build systems to capture that data. Then, having defined value, they then have to work on then how do we actually improve value? What's the care plan? What are the pause points in care and the key interventions around which we should be completely reliable in improving value? And so then, after that, what are the incentives we should use? Financial incentives and other kinds of incentives, and what are the performance metrics that we should use? So we can advance the slide. You can skip to the next slide. You can go on. Okay, so now I know that you cannot read these numbers, but these are the kinds of data that we are now giving to our hospitals and our doctors. I have blanked out the names of our hospitals here, but this is our value report card for myocardial infarction. And the top part of the figure is our outcomes measures, and it has mortality, and it has 30-day mortality, and readmissions to the hospital, returns to the emergency department. The bottom half shows our resource use, including our true costs. Now, I can tell you that when we give these data out, the first thing everyone does is they look to see, are they better than other places? The second thing they do is they look to see, are they worse than other places? And I can tell you they quickly realize that no one is the best. No one is the worst. On every one of the outcome measures, one of our hospitals is the best, and every hospital is the worst on something as well. In other words, there is something that might be learned for every hospital if they simply talk to their own colleagues. I'm Chinese American, and I always bring up this saying by Confucius, which is that if there are 3 people on the street in front of you, 2 of them could be your teachers. This means you have something to learn from almost everyone if you are open to learning. So this is not really for comparison. It's for you to try to get better by looking around and see who might have something to teach you. Next slide, please. I think that it'll do a couple little circles, and you can just go on to the next slide. Now, we know that there are many things that matter to patients that we do not currently capture. And so we've been asking groups of patients, what is important to you? What does matter? And we're finding out there are things that we don't currently collect. They're interested in how many days they're going, they want to maximize their time spent at home. They're not that interested in readmissions to the hospital. They want to know the percentage of days they'll be at home. They're they're interested in incontinence. They're interested in whether or not they're falling, but we don't collect that kind of data. So we can't tell them, what they can expect, and we can't work to try to get better. Now, if you can go advance to slide 1. You can just advance one. So what I added at the bottom is that what we have begun doing in Boston is we've begun using new methods for collecting what we call PROMs, patient-reported outcome measures, using patient portals on the internet, tablet computers, telephone interactive voice response systems. And so we're collecting data on how patients are doing, and with those data, we hope to improve our care. Now we can go to our next slide. Then, the way we're trying to improve our care is we're using the Gowandi tactics, the checklist. The recognition is that medicine is so complicated, no human being can be in control of everything. So there's a risk that obvious things might be overlooked. So the core values of the checklist are humility, discipline, and teamwork. We have to use the same language so we know what each other are expecting. We have to standardize what we do. We have to have clarity of roles. So we have been asking our teams to make these kind of things very clear so we can reduce our waste, harm, and chaos. Next slide. So we're not just doing this for disease states. We're doing this for groups of patients with similar needs. So we actually have a dashboard now for patients who die within Partners Healthcare System. We have a separate dashboard for patients who die with cancer, because we know that even though one outcome, death, is the same for all of them, we also know that there are varying ways, of dying. And so for the first time, I can tell you how many days our patients spend in the hospital in the last 6 months of their life, how many visits to the doctor, how many emergency department visits, how they rate their pain control. Because with those kind of data, we can try to improve. Without those data, everyone just comes to work and tries to do a good job every day. The checklist part of our end-of-life work is actually being led by Atul Gawande. He and his colleagues have developed an item checklist for what constitutes a good end-of-life conversation. There are questions like, what is your understanding of your prognosis? Do you have goals that we should understand, like getting to a wedding or a graduation? Are there states which are unacceptable to you, such as being intubated for a long period? Are there trade-offs that you would be willing to make? The seventh question is, have you discussed your thoughts on these issues with your family? So we're trying to take this same approach to groups of patients with complicated needs, including those patients who are dying in our system. Next slide. If we can advance the slide. So the BOMER part, the BOMER operations, is you need teams that have the responsibility for improving value, for getting better on the data that we are collecting on outcomes and cost. You need teams, and you need to give them the things that teams need. They need a scorecard. They need data. They need incentives, financial and non-financial. They need a leader who wakes up every day and thinks constantly about improving performance. And then they need formal and informal interactions among the team members so that they feel like a team, so they have pride in what they do, and that they feel embarrassed if they're not improving. So we can go to the very last slide I have. These are the 10 words that I hope resonate with you, and they come from the work of my friends Porter, Gawande, and Bomer. But I really do believe that our friend Jorge Pinto Ribeiro would embrace these values as well. I feel 100% confident that he would be completely comfortable with this approach. And the approach is that we need to become systems that are organized around value in healthcare, not just doing visits and operations, but improving value. In order to do that, we have to measure outcomes that matter to patients, and we have to measure the costs of our care so that we can try to improve efficiency. We have to have a culture of improvement, becoming better. I know that was very much what flowed through, Jorge's blood every single day of his life. And the way that you improve, the way you get better, is you try to learn. You can't just work harder. And what you usually learn in healthcare, if you're trying to improve value, is you learn how to collaborate. Other people are working together in ways that you had not thought of, or that may be difficult for your colleagues to embrace as something they could do because they don't even know other people are doing it. It takes humility. The humility to understand that you can get better and that you should get better, and that you might learn things from people in other institutions, and that you need to have the humility to use simple tools like checklists. And then you need the discipline to actually use those tools. And then finally, you need teamwork. You need teams that are focused on making all of these 10 themes real. I know from my time working with Jorge and talking with him over the years and visiting Porto Alegre that he would have embraced this approach. And I think my hope is that working with you, working with my old friend Carisi, with members of Jorge's family, that you will take your healthcare system and help make these kind of things real. And that when you do, you don't need pictures of Michael Porter, Atul Gawande, or Richard Bomer. You can put Jorge's picture there, and it will be completely appropriate. So with that, let me thank you for the chance to be part of your symposium honoring our dear friend Jorge. And I'm happy to take any questions or comments if it's technically feasible. Thank you very much.